Hi guys, welcome back to the channel. This is a real-time video showcasing USG-guided central venous line placement in the IJV. This is a 1 kg neonate suffering with hydrocephalus. This is a 45-day-old neonate and had a prolonged hospital stay. So the peripheral IV cannulation was difficult to obtain. So these are the vitals of the baby before starting the procedure, and the baby is being maintained with the respective saturation and vitals on HFNC, and there is an EVD also placed. So the first step is sterilizing the probe. We'll select a linear probe. In our case we have a hockey stick probe, and I prefer the 3 swab technique. I'll use sterilium followed by betadine and sterilium to sterilize the probe properly. And as you can see, now we have completed the sterilization of the probe. And now we'll clean and drape the baby well. Here also we are going to use the 3 swab technique only. As the skin of the baby is mature, we can use the sterilium and betadine and again sterilium. If the baby skin is not so matured and if it is on day 1 or day 2, we should not use sterilium. NS is preferred. After sterilizing the site and draping the baby, we open the central venous line. The items required are 2 gauze pieces, a guide wire and a catheter. They are placed in a sterile manner in the order of requirement. And now we take a copious amount of gel. I prefer lignocaine jelly as it prevents any hypothermia and any hypothermic reaction on a neonate. So first we need to keep the probe on the neck and visualize the vessels. See, the one present on the right side and it is being collapsed is the vein. It is the internal jugular vein, and the one which is on the left side, a smaller one which is not getting much affected with the pressure which I put by the probe, is the artery. And you can see the small one is also pulsating while the larger one is not much pulsating. So I have just increased the gain a little bit, and now I am piercing I am introducing the cannula into the neck. The whitish color which is approaching the vein is the tip of the cannula. As this is a 1 kg baby, there is no much space for me to manipulate the probe, and now we can see a brightish white spot which is present inside the vein. See, this is a telltale sign that the tip of the needle is within the vessel lumen. Now we can see in real time the cannula has a blood stain and there is backflow of the blood in the syringe, and there is good flow through the cannula. And now we'll close the cannula and we'll clean the site, as we have applied a little bit of jelly for ultrasonography. We'll clean the site so that there is decreased risk of any sepsis. And now we'll insert the guide wire. So we should insert the guide wire very slowly, and we should stop if we feel any resistance in between. We should insert nearly 40% of the length of the guide wire. If we insert more, it will go into the right atrium, and then we'll remove the cannula, keeping a gauze piece at the site of the puncture, as there will be bleeding. We need to keep the gauze piece at the site of the puncture, as it will prevent the bleed. And now we'll insert the catheter over the guide wire. This is modified Siltinger's technique for central venous line insertion. I have chosen to introduce the PICC catheter, which is a peripherally inserted central catheter, as this is a very small baby and its vein lumen will be very small. It can't accommodate a 3 French or 4 French central venous catheter. So after inserting the catheter completely, we'll remove the guide wire, and now you can see a small amount of backflow is coming. We need to readjust the catheter a little bit, and you can see the backflow which has come beautifully into the syringe. So that is the back flow, and now we'll seal the catheter with the cap. So this is how it looks. You can see the site of puncture is absolutely green, and there are no multiple pokes. So this is the advantage of USG-guided central venous line insertion. It decreases the number of attempts, and it decreases the risk of arterial puncture, and it decreases the risk of hematomas, and also the risk of sepsis, as it decreases the number of attempts. And we'll plaster the baby. We'll plaster it securely so that the line doesn't come out. And we'll finally check after plastering, because during plastering there can be a misplacement. We can see how smoothly the flush is being given, and we need to be cautious not to give more fluid because this is a preterm baby. And this is the vitals of the baby after completing the procedure. You can see the whole procedure went so easily and smoothly. So this is the advantage of USG guided central venous line. Hope this video helped you know all the steps and the procedure of central venous catheterization of IJV. Thank you.